Day of our 6th annual Skirboll Family Autism Conference. We're so excited to welcome you back for what is sure to be a wonderful end to your Friday. Before we get started, we want to go through a few housekeeping slides. First of all, we want to share a memory of Mort Skirboll. Our planning committee wanted to dedicate this entire conference to Mr. Mort Skirboll. He was a man who is going to be remembered for his compassion, that's going without my permission, and dedication to the community. And we're really appreciative to him and to the entire Skirboll Family Foundation for their support of today's event. We also want to recognize the Rochester Regional Center for Autism Spectrum Disorders for additional support, which is sponsored through the Department of Education in New York State. As well as a special thank you to Ibero-American Action League, who are providing Spanish interpretation for the event today. Spanish live interpretation is available by clicking that interpretation button at the bottom of your screen. You should see it reflected here. We are also asking participants to use the Q&A feature and not the chat. Oh, I'm sorry, this is like automatically scrolling. To use the Q&A feature and not the chat, because that will help us better manage the question and answers function. We will do a combination of answering questions during the session, as well as providing an opportunity for all panelists to answer questions at the end of the session. As an attendee, your video is automatically turned off. ASL interpretation should be spotlighted for you. Just make sure you selected side-by-side gallery under the view option in the upper right corner of your screen. We also want to take a moment to acknowledge our research registry. We are always looking for opportunities for participants for our various research studies. So if you're interested, please click the QR code. And we also want to share the link to a variety of resources that will be available to you at the end of the conference, including toolkits and local community resources. All right. Wonderful. This afternoon, our session is going to be focused on health equity, and health equity accounts for the multiple aspects of identity in a deliberate way, with special recognition for particular identities that might keep people from accessing relevant, timely, and high-quality services or full inclusion and participation in their communities of choice. So this idea of person-centeredness is really important as we think about health equity. And this is relevant to our community. We know we're all attuned to the equity issues in our own Rochester and broader community. So efforts that intentionally prioritize strategies to increase equity are critical, especially as they intersect with the disability identity. And so I'm so pleased to be introducing all of our panelists today who are doing various work in equity spaces. First, we're going to hear from Dr. Paciorkowski. We're going to then hear from Dr. Dennis Kuo. We will then hear from Meg McGee, and then finally, Dr. Laura Silverman. And I'm going to introduce them one at a time. So Dr. Paciorkowski, if you want to go ahead and start to share your slides, I will introduce you. Dr. Paciorkowski's overall career goal is to help improve the care of children with neurologic disability. Early in his training, he decided to focus on neurogenetics, as many causes of neurologic disorders in childhood have a genetic basis. After completion of his pediatrics and medical genetics training at the University of Connecticut, he trained in child neurology at Washington University in St. Louis. He currently engages patients at the University of Rochester as part of the Neurogenetics Consultation Service, the Hereditary Ataxia Program, and the Neurofibromatosis Program. He is interested in improving access to child neurology care in settings with limited resources and has participated in clinical and educational projects in Latin America and Sub-Saharan Africa. Dr. Paciorkowski is going to be speaking to us today on the economic status of families of youth with developmental disabilities in the United States and the intersection with food insecurity. Thank you for joining us.
Thank you so much, Dr. Adirola, and thank you, Dr. Hyman, for the invitation to join you this afternoon. And this, I think, is my second or third Skirboll conference, and it's such an important forum, a way for parents, caregivers, educators working with children with developmental diagnoses to come together. And I really appreciate the time that we're spending together this afternoon. As you just heard, I'm one of the neurogeneticists here at the University of Rochester. We have a 3-physician team in neurogenetics with 2 genetic counselors as well as a nurse practitioner. And we also train MD fellows as well. And we share a great number of patients with developmental pediatrics, of course, and a lot of the data that I'll be showing you today is some combined work that we've done together with faculty in developmental pediatrics. I use the terminology that's sort of accepted in the physician community per se. We're talking about intellectual and developmental disabilities, although these are really a broad family of diagnoses, which I think is more appropriate to capture the spectrum overall of functional abilities of our patients. But we know that there are about 6% of the children under the age of 15 in the United States have one type of developmental diagnosis or another. And 1 in 26 American families reports raising a child or multiple children with a developmental disability. Among these diagnoses, we feature autism spectrum disorders, which has quite a high prevalence, as we all know, 1 in about 54 children. Aged 8, cerebral palsy, which is sort of a more older traditional diagnostic category from child neurology, 1 in about 345 children. Intellectual disability, again, one of the older established diagnoses, is about, by definition, 1 in 100 children. And in our child neurology group, we see quite a number of children with intractable epilepsy who may have coexisting other diagnoses that I just mentioned above. In my career, which has now spanned some 20 years, we've seen a dramatic improvement in our ability to diagnose the underlying cause of many of these developmental conditions, be they a better understanding of prenatal environmental factors that may go into contributing to some of these diagnoses, to also a better understanding of the genetic landscape underlying autism, intellectual disability, and epilepsy as well. And there's really been a revolution in the technology leading to genetic diagnosis, which is a great deal of what we do in our neurogenetics clinic. However, the work here, I do want to advance my slide. There we go. The work here that I'm going to be talking about really comes out of, after all the genetics is said and done, what do we really spend most of our time talking about with our patients in clinic? What do our families appear to be overall experiencing? And these are topics that really orbit around struggles that our families come to face regarding obtaining medically indicated and appropriate things such as services through their school district, in-home nursing and respite care, access to mobility equipment, and transportation to and from medical appointments, assistance in obtaining supplementary income, not to mention the great struggle that our patients have accessing behavioral and mental health services. And we should also mention parent and caregiver mental health needs as well. This is actually the bulk of what I would say I do as a physician. I know this is the case among many pediatric specialists, but I think the team working in a whole, and let's remember our social workers are really unsung heroes as members of the team to help our families get through the day-to-day really practical needs that goes into raising a child with developmental diagnosis. So we became more and more interested in this in our clinical group, simply for the practical standpoint that this is seems to be true experience of our patients. I want to also just pause to reflect on how each of these struggles can be affected by where one lives, city, suburb, rural county, and how much one earns, whether some of these barriers are easy or difficult to surmount. We know overall, based on US Census data, that families raising or individuals at any age with a disability in a household earn less or are more likely to be below the federal poverty line. And this is based on multiple US Census data. So 20% of households having 1 or more members with disabilities were below the federal poverty line, compared to only 10% of households with no members with disabilities. More specifically, what do we know about the economic outcomes for families raising children with these developmental diagnoses? And we started by doing a review of the literature, and this graphic seeks to capture the interrelationships of themes that we observed in the medical literature, and among the social science literature as well, with all of this interconnectedness of nodes, if you will. Everything touches everything else. Starting over on the left, the family's income and wealth at the baseline, maybe at the time of birth of a child with a developmental diagnosis. And then all of the pathways and interconnections leading ultimately to the family's income and wealth at some point in the future. And knowing that certainly having a certain level of parental education directly relates to the level of parental employment over here, which may have direct relationship to access to healthcare and what type of insurance the family may have. Education also typically influences directly income, and income levels influence things like food insecurity and the risk that children with developmental disabilities may have toward malnutrition. All of these things are interrelated, and additionally putting in the experience, particularly in the United States, of racial injustice and discrimination, and how that may additionally impact a family's ability to overcome hurdles or barriers in this interconnected web of cause and effect. So this is the initial model that we knew on purpose, that everything's connected, but we really were interested in trying to understand whether there were particularly vulnerable nodes or connections within this model, because ultimately, if we want to improve policy and improve outcomes, we need to know what the most effective area is to address first. So we began to dig into it a little bit more by accessing publicly available data. These are data sources that anybody can look at. And we wanted to go from our model and particularly inquire in that data, what we could learn specifically related to families raising children with developmental diagnoses. There were 4 data sets. This is a bit of a busy table. I apologize for it. I think the main take home is the top dark blue, which lists the 4 data sets, and the line underneath that is where they come from. So the Centers for Disease Control has carried out a national survey of children with special healthcare needs. Of course, we have 2 pools of data, one here from the US Census Bureau and one hopping way over here on the right, also from the US Census Bureau, asking all kinds of routine questions that anybody who's answered the census knows that the census collects information on. In addition, there is a 2018 National Health Interview Survey. So some of these were typical report back by mail surveys like the US Census. Some of them were phone interviews, and some of them were actually face-to-face interviews. I think the main message going to the next slide in this table, looking at the sample size, these are in aggregate looking at millions of Americans across all demographic groups, and is really the largest data set available to answer the questions that we were asking. Because many of these identified children with developmental disorders and compared their economic outcomes to children who have who have typical development, and also children who might have some other medical diagnosis such as asthma or diabetes. Some of these surveys gave us a little more insight into comparatively what is the expense, if you will, or what is the outcome for the family economically that may be related more to these neurologic and neurodevelopmental diagnoses that might be different, for example, than raising a child with asthma or diabetes or migraines. So we did this work with some data science students who joined us for this project. And I'm going to go through some of the results for you. I think, again, the main message here when looking at this slide is the color coding. Blue will be children with neurodevelopmental, families raising children with neurodevelopmental diagnoses. Orange is families raising children who might have other diagnoses, such as diabetes or asthma. And then the red are families raising children with what we might call typical development. And we can see that overall, looking at, say, employment, there's an overall trend among families raising children with typical development to have a higher rate of employment compared to families raising children with a developmental diagnosis. Also, those families with typical children were more likely to have both parents in the workforce. Not surprisingly, this impacted overall average family income. Moving to the second line, we see that families over the red bar here, these are families with typically developing children tend to earn more than the families raising children with neurologic and developmental diagnoses. The final panel here also looks at the overrepresentation in the more wealthy families. These are families that are earning more than $100,000 a year. We see an overrepresentation of families with children with typical development, certainly compared to families here, 27% having children with a developmental diagnosis. And flipping the inverse, we see an overrepresentation among the poorest families earning less than $35,000 a year, an overrepresentation of those families raising a child with a developmental diagnosis. This also thematically continued when we looked at parental education levels. We see, again, an overrepresentation among families with developmentally typical children who have attained a college degree or higher. And then there's an interesting trend which we think emerges in this group of this table, this figure here, and also over here it's represented as well, an overrepresentation in those who look like they started college but not finished. And those tend to be more likely to be families with a child with a developmental diagnosis. So suggesting that there is something that is occurring perhaps during those prime end of education, early beginning your career years, when families are also typically having children, where if there's a birth of a child with a developmental diagnosis, families may curtail completing their education, and this may lead to an effect on overall family income, certainly long term. Down in the bottom, not surprisingly, in terms of distribution of insurance type, we see that overwhelmingly families that are raising a developmentally typical child may have insurance through their employer. And that's contrasted with families that might tend to be on a government assistance plan, who might tend to have a child with a medical or a developmental diagnosis. Also concerningly is in terms of food security. The numbers look small, but I think they're telling, is that you have 90% of families who are raising a developmentally typical child have never experienced a lack of food, whereas that number is only 78% if they're raising a developmentally diagnosed child. And over here, the sometimes true and often true is higher for the families raising developmentally diagnosed affected children as well. I would just put food security as one of those really severe distillations of economic hardship in the U.S. because we tend to think of our country as not having widespread food insecurity. At least that's what we tend to think. We also stratified out results for white Americans from results for Black Americans, and looking at the same categories that I've just presented, found some concerning and disturbing trends pretty much across the board. Certainly, in terms of education level, we see that although parents attaining a college degree or higher was around the 40% across the board for all types of children, those numbers dropped for Black Americans to about 20% if they're raising a child with a developmental diagnosis. We also tend to see an increase relatively in that phenomenon I mentioned earlier of those who started college but not completed college. Those numbers tend to be overrepresented among Black families raising children with developmental diagnoses. Total combined family income and average family income as well are similarly concerning. What is really apparent is that overall, Black Americans who have a child with a developmental diagnosis are much less likely if you look at this column, to be earning over $100,000 or more, and are much more likely to be in this lowest income group. And this is overall represented in terms of the average family income, but we can see that there's really a much lower numbers. This is all across all groups for overall family income for Black Americans. What was interesting beyond that was that did not appear to be reflected in full-time employment to that dramatic an extent, suggesting that although Black Americans have similar full-time employment numbers, their overall average family income is lower, which should just be a concerning observation all around. So there has been a area of literature in developmental disabilities looking at racial disparities in the prevalence and outcomes of various diagnoses. For example, it's been published that Black Americans have a higher rate of epilepsy than white Americans, even when adjusted for age, education, and income. Also, it's been reported that Black children are more likely to be diagnosed with more severe cerebral palsy than white children. And this literature, while it's interesting, can promote the belief that there are some biological differences associated with these cultural constructs that we call race. But we also need to remember that they actually illustrate that there is a significant experience of racial injustice leading to these disparities in health outcomes in the United States. This is, I think, been very clearly illustrated in the literature looking at disparities in the diagnosis of autism spectrum disorders. There have been several recent publications illustrating how Black children with autism are diagnosed later. One paper by John Constantino in 2020 found that Black children with autism were diagnosed on the average of 42 months after their parents first reported concerns about their development. Similarly, another paper the same year found essentially the same thing, that one of the biggest factors associated with not having a diagnosis of autism, despite meeting the diagnosis criteria, was being of non-white race. So there's a true disparity in the rate of diagnosis of Black children with autism. And if we think about how important it is for early diagnosis to accessing appropriate care and long-term services, this again should raise considerable alarm. I'm just going to go really quickly through some of the historical underpinnings of this racial disparity in the United States. There have been several waves of migrations of Black Americans from the rural South during the 1920s and 30s, and again during World War II and the immediate post-war era up to 1970, where families from the South moved to more industrialized cities in the North. And this is associated often with a disproportionate relocation of white Americans to suburbs, and leaving the resulting urban environment to have a decrease in public spending. And to this day, the economics literature is filled with examples of how disparities in access to education, healthcare, and other public services remain. Black Americans also, on their arrival to northern cities, faced policies of redlining, where this is a practice of restricting lending to certain neighborhoods based on skin color, and restrictive covenants. So sales and rental properties were only given to members of certain groups in certain geographic areas. And even though these practices were outlawed in the 60s and 70s, again, the economics literature does have numerous reports of instances in many cities where this practice is continued. Papers published as recently as 1999, illustrating the effects of continued, essentially segregation of housing environment. Overall, these practices have reduced Black home ownership rates. And in the United States, home ownership is a significant percentage of a family's overall monetary value, if you think of in terms of investments. This is a map of our hometown, Rochester, showing some of the red line districts where these restrictive covenants were in place. This is a public document. So by 2017, the Federal Reserve had data to the effect that the overall net worth of Black families was about 15% of that of white families in the United States. And we found that this experience with racial injustice and the consequences could be barely mentioned or or ignored altogether. And many of the papers that we've reviewed as part of this project, looking at the outcomes economically of families with children with disabilities, this is just one. There's only really one long-running case control study. And we love case control studies because this can clarify some of the cause and effect for economic outcomes in particular. And looking at the economic trajectory of families with children with neurodevelopmental diagnoses, they noted in their results that 79% of the families in the persistent poverty group were non-white, while 78% of the persistent non-poverty group was white. But yet this factor was not mentioned further in the discussion in this rather recent paper. So we think this is an under-analyzed, under-studied aspect to this conversation. And where we're going from here is we're seeking to collect longitudinal data more closer to home in upstate New York, looking at urban, suburban, and rural families with and without children with developmental diagnoses, with the goal of developing a predictive model. We're interested in identifying which of these nodes in particular are more important in this network that we could impact with policy, whether it's location of residence, whether it's healthcare access, whether it's parent education level, whether it's something else, and also what do the experiences of racial injustice have on this overall predictive model of risk, and is it possible to quantify the effects on families of this experience with racial discrimination? In conclusion, we found that families raising a child with a developmental diagnosis experience overall a decrease in parental employment. There is also decreased family income. We talked about total combined family income being more likely to be below $35,000 and less likely to be above $100,000 for families raising children with developmental diagnoses. Families with children with developmental diagnoses were also more likely to have started but not have completed college, and were also more likely to have experienced food insecurity. And when we looked at Black Americans in particular, we found that these disparities were, if anything, amplified overall categories. I wanted to thank you for your kind attention. I hope that you found this information interesting and compelling, and our group does think that this is an important aspect as we look to improve care overall for children with developmental diagnoses, and I welcome any questions you might have. Thank you very much.
Dr. Paciorkowski, thank you so much for really diving into the financial and psychosocial implications of raising a child with a disability. And I also appreciate your full acknowledgement of how historical policy decisions have perpetuated racial injustice, not only for people with disabilities, but for our communities as a whole. I think like the bright part of what you shared is that connectiveness, which reminds us all of our collective responsibility for equity and promoting equity for our collective community members. So thank you for that. We will be taking questions at the end, but if you have questions for Dr. Paciorkowski, feel free to put them in the Q&A and he might be able to respond to them as our next panelists present. So with that, I'm going to, with excitement, turn it over to introduce Dr. Dennis Kuo, who is a professor of pediatrics and our new chief of developmental and behavioral pediatrics at the University of Rochester Medical Center and Golisano Children's Hospital. Dr. Kuo received his medical degree at the University of Pennsylvania and completed his pediatrics residency at the University of North Carolina Hospitals, with a fellowship in general academic pediatrics at Johns Hopkins University. Dr. Kuo has a longstanding interest in the care of children with disabilities and medical complexity, including systems of care, early childhood, and health equity. Dr. Kuo is the immediate past chair of the Council on Children with Disabilities for the American Academy of Pediatrics. And we are so excited to hear from him today as he presents on the National Research Agenda for Health Equity for Children and Youth with Special Healthcare Needs. Thank you for joining us, Dr. Kuo.
Good afternoon, everybody. What a pleasure to be here. This is a talk that's really more high level regarding national agendas and policies regarding children and youth with special healthcare needs. many of my slides today, especially the ones that I've noted on the lower left-hand corner, will have the HRSA logo. HRSA is the Health Resources and Services Administration. And I want to acknowledge two colleagues at HRSA, Trevi Bound and Sarah Beth McClellan, who are collaborators and co-authors on much of the Blueprint's work. They actually led a lot of the development of the Blueprint, and they have shared a number of slides that you'll note, the ones that have the HRSA logo. Because so much of this is actually policies and programs that come from federal, national programming, I want to start with a few definitions. In particular, the policy of the Blueprint concerns children and youth with special health care needs. The Maternal and Child Health Bureau, which is a bureau under HRSA, is defining children and youth with special health care needs as those children who have or are at increased risk for chronic physical, developmental, behavioral, or emotional conditions, and who also require health and risk-related services of a type and beyond that required for children generally. And this definition encompasses programming and policies for a very wide range of conditions and diagnoses related to increased service need and use, and that includes everything from asthma to spina bifida and autism. And autism is very much within this category of children used to special healthcare needs. And the reason this definition and this program exists is because at the federal level and then trickling down to the states, HRSA has a wide, longstanding interest in the care and development and health and the growth of children with disabilities and special healthcare needs, dating many, many decades. I do want to acknowledge that children used to special healthcare needs is a term that's used within federal policies. It is person first language, and you will see person first language is largely used throughout this presentation, acknowledging the preferences for identity first language that is increasingly common as well. So to bring it back to autism, children with autism are very much within this group of special healthcare needs because children with autism require health and related services beyond those required by children generally. And that includes, for example, subspecialty care such as developmental behavioral pediatrics and other subspecialty fields that may be addressing co-related or co-occurring conditions that may occur in with an autism diagnosis. And children with autism often require therapies and educational services, often found within the educational setting, and some have additional subspecialty care and medication needs. And children with autism often exhibit a higher level of caregiver needs and healthcare costs, which is why they go into the general federal program category of chronic conditions, special healthcare needs. I want to take some time to look at for us to look at the Maternal and Child Health Bureau strategic plan. And the Maternal and Child Health Bureau is a bureau underneath HRSA. It is responsible for improving the health and well-being of America's mothers, children, and families. And a vision is an America where all mothers, children, and families thrive and reach their full potential. And note that when we talk about full potential, it is not the absence of disease. It is about acknowledging the growth and potential for all individuals. In the case of children, it's about maximizing and acknowledging their developmental potential. And the goals for MCHB and their strategic plan is to assure access to high quality and equitable health services, to optimize health and well-being for all MCH populations, to achieve health equity for MCH populations, to strengthen in public health capacity and workforce for MCH populations, and to maximize impact through leadership, partnership, and stewardship. To achieve the health and wellness of all children, MCHB has developed 6 indicators of what they call a well-functioning system for children with special healthcare needs. There is a foundational aspect of ensuring that all children receive family-centered care and that all services and system components are delivered with cultural and linguistic competence. to have a well-functioning system of care that allows children that builds towards health and wellness and development potential, individual and families in the middle of the system, and going from the top and going clockwise, the system has components of families as partners at all levels of decision making, that all children have a comprehensive coordinated medical home, that all children and families have adequate insurance, that all children have early and continuous screening for developmental delays and co-occurring conditions such as mental health comorbidities, and also social determinants of health screening such as food insecurity. Community-based services, in particular, that community-based services such as transportation and therapies are available so that families can utilize them easily. And finally, last but not least, transition to adulthood to ensure that all children have a planned and proactive transition to the adult healthcare system and systems of care at the appropriate age. And when we examine autism, these are components of a system of services that support health, growth, wellness, and development, including a primary care medical home, a developmental pediatrician with developmental behavioral pediatric services. The education system, of course, ensuring adequate, least restrictive environment, services in the educational setting that promotes that the child's education development reaches its maximum potential. Adequate and continuous insurance, the availability of communities-based therapies, and some children will benefit from medications to address certain symptoms that may arise. But I want to also emphasize that a system is not just a component, it's also the journey. And what I mean by the journey is that it's longitudinal. You start in one place, you go through another place, you go from place to system to component to system. You may travel from primary care to developmental pediatrician to school to therapies and such. And we have to understand that these systems are often fragmented. They are often supported by different laws, they're supported by different training, different finances. The identification of autism often, not always, but often occurs in the medical system because children come to the pediatrician or family medicine doctor for frequent well-child visits in the first 2 years of life. And then as the system transitions over to the school setting, the treatment begins to straddle different sectors. And yet we find families widely report that there is no roadmap about how to get through the system in a predictable way. The system is widely acknowledged to be fragmented. It's not predictable, and families report in the literature as well as informally that the families are often the ones figuring out how to navigate through the system. So I want to talk about the Blueprint for Children and Youth with Special Healthcare Needs. And MCHB released the blueprint in June of 2022, and I had the privilege of being part of the steering committee group, as well as one of the authors of their papers. It's been over 20 years since the last strategic planning happened for the system, and the recent data from the National Survey for Children's Health tell us that the current system of services really could use additional attention. That the system of services just continues to be fragmented, that it's not really well coordinated. And even though 1 in 5 children have a special healthcare need, 85% of families report that they're not receiving care in a well-functioning system. We also need to acknowledge the recent impacts of the COVID-19 pandemic, natural disasters, and social economic arrests that also have disproportionate impacts on children with special healthcare needs. I've took this data from the 2020 and 2021 National Survey of Children's Health, which shows that within the group of children with special healthcare needs, that there are additional disparities of children with autism. The middle column, you have children with autism. On the right-hand column, you have children without autism. You'll see that more children who have autism, their caregivers report that they don't receive care in a well-functioning system. A higher proportion of parents and caregivers report that the children with autism do not have a medical home, that they don't have continuous and adequate insurance, and they don't demonstrate family resiliency. The Blueprint for Change for Children Youth with Special Healthcare Needs really kicked off in the fall of 2019. This happened before the COVID pandemic started. Convened steering committee consisting of numerous specialists and most importantly, family stakeholders that came together to design what this blueprint was going to look like. I was part of the group that was convening in fall of 2019. We were asked to be aspirational. We said, just put it together, tell us where we need to go. This is what's going to be driving our programming and policies for the next 15 years. The COVID pandemic hit. We looked at each other through Zoom and said, you know what, we just got to keep going because there's a time where we really are seeing disruption and the system really needs our attention. It's now. There was a National Children Youth with Special Healthcare Needs Summit in the fall of 2020. Over 150 invited participants attended. We started to coalesce in 4 focus areas that I will get into in the next several slides. In the fall of 2020, there was a public request for information that received over 70 responses from a variety of stakeholders. In 2021, authoring groups were convened to write a number of component papers, and this culminated in June of 2022 with the release of a Blueprint from Change. The Blueprint for Change is published in its entirety in a supplement to the journal Pediatrics. It is one of our the journals that where a lot of our research studies in pediatrics is found. There is a link to the HRSA site for the blueprint at the end of the slides. The importance of the blueprint for the field is that it does align with the 6 indicators framework for the system with for children with youth with special healthcare needs. But what it provides are 4 focus areas of where policies and programming and funding will be aligned with over the next 15 years. So it really provides a new lens of equity, access, and life to the framework of systems of care, and it provides principles and recommendations for the field in several areas, including for families, researchers, providers, policymakers, and programs at the local, state, and federal levels. We started when the blueprint was being developed, several guiding assumptions that I want to highlight here. On the upper left-hand corner, disability is a natural part of the human experience and in no way diminishes the right of individuals to participate in or contribute to society. To the right, racism is a social risk factor that has a profound impact on the health status of children, adolescents, young adults, and their families. Lower left-hand corner, children with special healthcare needs require more and different types of services than those for typically developing children and youth, yet the current system is not ensuring access to these services, particularly for children with special healthcare needs impacted by poverty and discrimination. Lower right-hand corner, children with special healthcare needs are more severely impacted by the adverse effects of social determinants of health and inequities. This diagram, which is found in the blueprint, highlights the 4 focus areas of discussion within the blueprint for children with special healthcare needs. At the center, you'll see that we start with children with special healthcare needs enjoy a full life. That is the goal, to a full life and thrive in their community from childhood through adulthood. There are 4 focus areas that will be driving the blueprint. On the top, you'll see quality of life and well-being. On the right-hand side, it's access to services. At the bottom, it's financing of services. And the left-hand side, it's health equity. So we'll delve into these 4 areas, but it's important to understand that these 4 areas for the blueprint for discussion intertwine with each other. You cannot have health equity without quality of life and well-being, access to services, and financing of services. Under health equity, the vision for our programming policies going forward is that all children who use special healthcare needs have a fair and just opportunity to be as healthy as possible and thrive throughout their lives without discrimination and regardless of the circumstances in which they were born or live. The principles published in the blueprint are acknowledging and pushing us forward that structural and systemic causal barriers to health equity are eliminated, including discrimination, poverty, and other social risk factors, and that sector systems and programs that fund, deliver, and monitor services and supports for children with special healthcare needs are designed and implemented to reduce health disparities and improve health outcomes for all children with special healthcare needs. Family and child well-being and quality of life. The vision in this focus area is that the service system prioritizes quality of life, well-being, and supports flourishing for children and youth with special healthcare needs and their families. With the principles in the blueprint that families, regardless of circumstance, can access high-quality, affordable, community-based services that support the medical, behavioral, social, and emotional well-being of the child or youth and whole family. And that health systems place value on the measurement and use of both child and family well-being and quality of life outcomes and health outcomes. Note that under this focus area, that we're really trying to emphasize what is meaningful for children and families and not necessarily just the healthcare system outcomes. Access to services, the vision is that children and youth with special healthcare needs and their families have timely access to the integrated, easy to navigate, high quality healthcare and supports they need, including but not limited to physical, oral, and behavioral health providers, home and community-based supports, and care coordination throughout the life course. With the principles that all services and supports at the individual, family, community, and provider levels are easy for families and professionals to navigate when, where, and how they need them. The workforce is trained to meet the needs of children and youth with special healthcare needs and their families, reflects the families and communities they serve, and is culturally responsive. Service sectors increase the ability of children and youth with special healthcare needs and their families to access services by addressing administrative and other processes that hinder access. An additional note about the access to services focus area, and I'll say this as one of the authors for this paper, is that we started with saying that we need the end result of healthy growth and development and wellness as the driving force to determine what services are needed. That we want to make sure that we're looking at the goal of health and wellness in mind and not whether simply a child got the service. The fourth focus area is financing of services, with the vision that healthcare and other related services are accessible, affordable, comprehensive, and continuous, and they prioritize the well-being of children and youth with special healthcare needs and families. With the underlying principles that healthcare and other related services for children and youth with special healthcare needs and families are financed and paid for in ways that support and maximize an individual's values and choice in meeting their needs. Health and social service sector investments address social determinants of health to increase family well-being and flourishing. That payers and service sectors adopt value-based payment strategies that support families, advance equity, and incorporate continuous quality improvement by enhancing team-based integrated care. A word that I'll say about the financing of services is that it specifically states in the paper published in Pediatrics that we need to view children's health as an investment and not a place where we can cut costs to save money. So in summary, what's new with the blueprint is that it is a call at the federal policy level and to influence policies and programs at the state and local level. It is a call to address the upstream and downstream factors that prevent children and youth with special healthcare needs from a fair and just opportunity to be healthy. A call for healthcare systems to measure outcomes that are meaningful to children and families. A call to design a system that is built around the needs of children and families, not just a diagnosis or a treatment protocol. A call to support a service system that supports access, equity, and integration and eases the financial burden on families. So how the blueprint is going to influence the field, really the field of policies, initiatives for programs. It is the bar. HRSA asked us developing the blueprint to be aspirational, to say, this is where it needs to go. This is what we want to achieve over the next 15 years. In my view, this is how it looks. One is that integration of family partners at all levels of care and in the system. That includes at the clinical setting, that includes in organizations, that includes in research, that includes at policies, that includes in work groups. And that is because family partners, including self-advocates, have the understanding and the lived experience of the system, of how it gets navigated, what the journey is like, and the stress and the challenges that folks face by going from component to component. Equity, health equity, equity in outcomes is addressed upfront, that every component it has to be designed with the understanding that there are structural determinants of health, including racism and poverty, that intertwine with the experience of a disabled individual, and that has to be addressed upfront. There is an emphasis on lived experiences, journeys, and design. Lived experience talks about how not just going from component to component, but the pathway and the predictability of going from component to component, so that the journey is developed, the journey is predictable, and that the journey is as easy as possible. When we think about how we access services, and you compare it to other things like something as simple as going to the store to get a bottle of like say a bottle of mouthwash or toothpaste, you know where to go, you know how to find it in the store, you know how to pay for it, and you enjoy the experience of actually utilizing the product. If we could think about how we utilize our services of getting through raising a child and then having the lived experience of being an autistic person, and recognizing it as a journey that is just as valued and is important and pleasurable and delightful as any other experience, that is when we know that we will have achieved equity in lived experiences. And again, the 4 areas of the blueprint are completely intertwined: equity, family and child well-being, access to services, and financing of services. As we go forward, these are some reflection questions that I will be posing. What can we learn from the blueprint and its applicability for autism? What does health equity look like for children with autism and their families? And then what does that roadmap look like for an autistic child and their families? And what does equity look like for autism? A predictable journey, perhaps through services, including the screening, the follow-up, the service delivery, and the transition through the sectors: healthcare, education, financial. Office design, physical design, staff training to accommodate and welcome every child and family's needs. The inclusion of family partners and individuals with lived experience at all sectors of services. A roadmap of services and resources. I started out with the concept of a roadmap because a roadmap of raising a child and then getting through the lived experience, when a child is typically developing, there is a roadmap that I think folks really know and understand, such as the expectation that you go to school in kindergarten by a certain age, typically 5 years of age. When you finish high school, that there will be a life path in front of you that is predictable, that you may have dreams and plan of. And when you have a diagnosis, when you get a diagnosis, those plans start to change. In some cases, we'll hear families tell us that they get derailed. That roadmap is important to plot out, no matter what kind of diagnosis may be in front of us, what kind of needs happen, what the challenges are. There always should be a roadmap, and getting to that roadmap of services, resources, and building that roadmap with empathy is what the blueprint is all about. So what comes next? As I mentioned, the blueprint is aspirational. This is a very, very high level. We are now at the point where we're talking about these are the foundational focus areas of how we want to see the system of services for children with special healthcare needs to unfold over the next 15 years. What's next is that children with autism enjoy a full life and thrive in systems that ensure dignity, autonomy, and independence in their communities. But this blueprint is just being rolled out. It's brand new. We are now engaging stakeholders and talking about it's here. This is what we want to see with our programming, with our policies. Expect these 4 focus areas, expect these 4 sectors: equity, outcomes with quality of life, access to services, financing, expect them to influence programming over the next 15 years, not just under HRSA and the Maternal and Child Health Bureau, but other federal and state initiatives. In the meantime, when working with stakeholders, when working with policymakers, when working with each other and organizations, I encourage folks, as they're taking action, to use the blueprint as the lens by which we're going to be looking at programming for all systems. And I've included here more information about the blueprint for children and youth with special healthcare needs. This is the website under the Maternal and Child Health Bureau. You'll find there the blueprint, you'll find graphics, you'll find initiatives. And I will end the presentation, and then I will be happy to take questions. Thank you.
Thank you so much, Dr. Kuo. We're all incredibly lucky that you're exerting your influence on the national level. And this systems level perspective really highlights both how far we've come, but how far we have left to go. And I was very struck by your point that the system cannot be disentangled from quality of life and overall lived experience. And I think that we can't forget that if we really want to truly invest in our children's future. So thank you for this presentation. I'll encourage you to respond to questions through the Q&A, and hopefully we'll have some time at the end for some live responses. I do want to now turn our attention over to Meg McGee. I'm so happy to welcome her here today. She is a longtime colleague and friend, and I know that she's well known to many of you as a behavioral consultant through the Community Consultation Program in the Division of Developmental and Behavioral Pediatrics. She coordinates the clinical training in behavior analysis for the B.C.B.A. program at the Warner School of Education. And as an expert clinician, Ms. McGee has seen the impact of stress, trauma, and poverty on children and youth with autism and other developmental disabilities. We are incredibly lucky that she is here today to talk to us about trauma-informed care for youth with autism spectrum disorder. Thank you for being here, Meg.
Thank you, Susanna. I'm so happy to be here. Thank you to everybody else who's also in attendance. First and foremost, I would like to put out there that any sort of discussion regarding trauma can be uncomfortable based on our own lived experiences throughout our lifetimes. And so I just humbly request that people take care, that if during any point in this conversation or presentation that you need to leave or take care of yourself, please do so. Okay. My hope for today, after our brief time together, is that I will have done some due justice in increasing your knowledge of some very complex topics and complex interventions and complex service considerations. So we're going to talk a little bit about what developmental trauma is and why we consider it a framework versus a diagnosis, the complexities that can exist when we have layers of need or identity in terms of autism spectrum disorder, developmental trauma, and the presence or occurrence of challenging behavior, some specific considerations in the assessment of challenging behavior for someone who has experienced trauma, and my thoughts on trauma-informed care moving forward. I bring some assumptions to this talk that I wanted to share with you. One is that trauma is real, and it's particularly real for whom the experience impacts. One of the challenges of doing work and study in trauma is that an event that someone perceives as traumatic for themselves may not serve that same sort of trauma response for another person who experienced the exact same event at the exact same time. So I go into this with absolute humility and recognition that trauma is an individualized lived experience. Also, that trauma is prevalent in our society. That trauma has true impact on neurodevelopment and can have immediate and long-lasting effects on learning and development. That we as a human service community need to be better prepared to serve and support children and families who have experienced trauma, and that children are just the best and they're resilient. And when given positive learning environments and nurturing relationships, they can grow and succeed. This definition of trauma is quite broad, and I choose it as my working definition for that reason. I feel it encapsulates the experience of any sort of lived individual who experiences trauma. So the definition, individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically and or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and or social well-being. I'm not sure that there's much left out of that definition, but that's sort of, that is the working construct as I proceed forward with this talk. A brief distinction here about trauma and how trauma is represented in literature and research. If anybody has ever just searched trauma, you better be prepared to get a lot of information about sort of ER procedures, emergency room responses to physical trauma from accidents and such. That is not what we're talking about today. We're talking about mental health presentations of trauma. And acute trauma refers to a single accident or incident, which could be something like an accident or a natural event or catastrophe like a hurricane or a fire. Chronic trauma in the literature refers to those things that happen more than once, so either repeated or sustains for a long period of time. My reference in our discussion today refers to complex trauma, which is also referred to as developmental trauma, and that results from exposure to varied and multiple traumatic events, often of an invasive or interpersonal nature. So we're really talking about relationships and relationships that are vulnerable and relationships that may yield in some negative sort of response or outcome. You know, there's a study that says that adults with autism are 4 times more likely to be diagnosed with post-traumatic stress disorder. And it was that study that led me to begin my venture into the world of trauma and trauma experiences for the autistic individual. And I was very surprised in my initial studies, which is why I wanted to share this slide, is the overlap of symptom or perceived symptom of autism and PTSD. And it brought up for me this concept of diagnostic overshadowing, when particular symptoms look like one disorder when really they could be related to another disorder, but because of the way that we construct them and view them, we're not necessarily getting as complete of a picture as we could otherwise. When in 2017, I was part of a small research group, and we looked at specifically how the behavioral literature discussed the occurrence of trauma and the trauma experience for individuals with developmental disabilities, a much broader catchment. And we were stunned to find that the behavior literature did not talk about trauma or the trauma occurrence and as how it related to challenging behavior. To stand up and say there were 0 occurrences was actually quite an embarrassing sort of recognition within my field that we weren't looking at this particular subset of need, that individuals who identify as autistic or other with other neurodevelopmental difference weren't being heard about what their experiences were with trauma. So I had to leave my behavioral literature and begin to look at lots of other sources of information. And really became an avid reader of Dr. Bessel van der Kolk, who has been studying complex trauma for decades. And there was recognition that children in the US, especially those that were experiencing maltreatment, were struggling. And we needed, as a country and as a service system, figure out how to respond so that we can improve the lived experience of these children. And as a result of that, the Complex Trauma Study Task Force was created, and they put out a survey between the years of 2002 and 2003. And they got the input of 17,000 clinicians who were serving children of maltreatment. And 80% of the children had been exposed to multiple or prolonged interpersonal trauma. Yet of those 80%, only 25% met the existing criteria for post-traumatic stress disorder. The distinction of developmental trauma or complex trauma was a necessity, as the experiences of adults reported by adults did not illustrate the experiences of children. This was first represented by this task force and has been the foundation for subsequent study in this area. So when we look at the developmental trauma framework, I decided to break it out into two different illustrations for you. One is the diagnostics, right? So those areas of diagnostic consideration when diagnosing somebody with trauma. And the second is what it looks like when we're out and about in the community. I am a community provider. I am not a diagnostician. And so I see the lived experience and want to understand what's contributing to this lived experience for this child. And like I said, I'm not a diagnostician, but I work with some really exceptional ones. And what children experience in the real world of homes and schools, classrooms, communities, informs the symptoms that relate to diagnosis, though. And reflecting on all of this, I knew there had to be more to the picture for some of the children that I was working with. And I say children because that's who I work with predominantly. You know, when we look at this, we see the unfortunate reality of trauma is that children are being exposed to things that they really developmentally shouldn't be. And that's having a negative impact on their development. We're also seeing how that exposure impacts them in terms of their broader understanding of emotions, their ability to manage their own emotions or understand other people's emotions, impacting their resilience and endurance for attention and learning, especially in social environments, and learning how to engage with others, make friendships, and be successful in whatever capacity, whether on a sports team or in a classroom. All of it is very hard. And if one of the takeaways for all of this is that it's hard, the lived experience for a child who is engaged or who has experienced trauma. I say framework because despite developmental trauma being proposed to the Diagnostic and Statistical Manual 5, which was published in 2013, it ultimately was not included. And I don't want to get into all the reasons why it was not included, but the response from the service community is that there is still very much significant value in considering what was proposed to be included. And what that framework illustrates is that how difficult and how complex trauma experiences are, much less when we layer identity and experiences. Dr. Kuo's experience discussion of health disparity, when we start to layer identity and experience on these the premise of trauma, it gets even more complex and more challenging to determine appropriate treatment and intervention. despite its not being included, the realities still exist within our society. And those include that 2/3 of youth experience at least one potentially traumatic event by the age of 16. And that those forms of trauma take a variety of, happen in a variety of ways. And we have this whole other layer of the COVID pandemic now being a variable in consideration of contributing to the multiple forms and the duration and complexity of trauma. And then specifically looking at the experiences of autistic children are significant risk for experiencing adverse events in their communities and learning environments. I was looking at a study even just last night that I didn't get through, so I couldn't give you the exact numbers on, but we're beginning to see the evolution of research in terms of the adverse childhood experiences specific to the autistic individual. And it's more significant for the autistic individual than it is for neurotypical peers. And while the recognition of trauma and the impact of traumatic events is recognized and is continuing to grow, there is still significant, there's still the significant risk of under-identification and under-treatment due to a shortage of treatment providers who understand trauma and autism spectrum disorder. Here we have some overlapping observations of autism and developmental trauma. And without going through all of them, I think one would be hard pressed to say which observation originated from trauma and which observation originated from the field of autism. These are the overlaps that make diagnostics and treatment considerations very, very difficult. When we consider a developmental response to trauma, it's important to recognize that all children express some kind of reaction, distress, or behavioral change following a traumatic event. And with that recognition, we begin to think about concepts of trauma-informed care. Usually, if there's challenging behavior involved, that's when I arrive to the team. And just in the effort of making no assumptions, one of my tasks is to try to understand why behavior is happening. And we use a simple sort of contingency of what happened before a behavior, the occurrence of a behavior, and what happens after a behavior. This is pretty familiar information. We also have several variables and considerations that influence our behavior that we may not see in that environment. It may not be directly related to the occurrence of that behavior, meaning it may not be observable in that environment, or it may not be temporally related to the occurrence of that behavior, but it does influence our behavior. And so I have 4 different considerations of how a provider could conceptualize trauma and its impact in the environment for the individual and the individual with autism. The first is trauma as an influence on behavior. In a very behavioral way, we call this establishing operations. It influences whether or not we find something valuable or reinforcing at any given time. We may not be able to recognize it in the moment, but understanding trauma and trauma history and its impact for that individual is incredibly helpful in anticipating this particular scenario. Because the trauma experience can never, quote unquote, go away for that individual, we just have to recognize that as being part of the equation at all times. However, we also run into other situations where the trauma may have a more significant and apparent role in the environment. So for example, we may have something that happens in the environment prior to a challenging behavior that is directly related to that trauma experience for that individual in their past. And therefore, what we may not understand may actually have a clear correlation and consideration as to why challenging behavior is happening for that individual. The second is the experience of trauma reenactment, and that's when the behavior itself is actually a demonstration of the trauma that was experienced. And so in simply terms, they're just imitating what has happened to them or is happening to them. And that's the behavior that we're actually seeing in the environment. And then the consequence, the thing that happens after challenging behavior, may be related again to that trauma experience. And we have to evaluate that as to if the consequence or response to challenging behavior then serves as a contributing factor and variable in sustaining challenges both in the moment and long term. A trauma-informed approach, often referred to as trauma-informed care, is a promising model for organizational change in health and behavioral health, and other settings that promotes resilience in staff and patients. And we hear a lot about trauma-informed care or compassion care, both in popular media, but also in academic and medical settings. And I wanted to share the University of Buffalo's sort of framework of trauma-informed care. This includes safety, choice, collaboration, trustworthiness, and empowerment. And the piece that also I think is important to recognize is that these are qualities that are actually actioned in professional specific ethics codes and practice guidelines. And so if someone is being a fully ethical practitioner and compassionate provider, that engaging in trauma-informed care is not an entirely new practice or new framework of intervention. It is sort of recognizing these things that are considered trauma-informed and where we find them in our practice and where we amplify them or modify them to assure that they are trauma-informed. So to be a trauma-informed provider in this area, or a trauma-informed provider in this area of trauma, autism spectrum disorder, and challenging behavior, compassion is key, and understanding trauma-informed practices is really at the foundation. And then as we go up this pyramid, having a deep understanding of autism, developmental trauma, and challenging behavior is key to effectively serving this population. And that's through the utilization of evidence-based practices that we can evaluate and then intersect and combine from all the fields who contribute to the health and well-being of individuals in this circumstance. And then finally, at the pinnacle, the more we understand and the deeper we understand and engage families in treatment and assessment of this intersection of autism, trauma, and challenging behavior, the more effective and the healthier the family system and the individual will be. Thank you.
Meg, thank you so much for sharing your expertise, because this intentional consideration of trauma that you described, of trauma in all its forms, is such a critical component of person-centered care. So thank you for sharing the unique ways that trauma might show up or relate to experiences through a developmental lens. We appreciate you. All right, I am going to introduce our last panelist for the day, and I'm so excited to introduce Dr. Laura Silverman, who is an associate professor of pediatrics and a clinical psychologist. specializing in working closely with families and children with autism and developmental disabilities. Dr. Silverman is the director of the Leadership Education in Neurodevelopmental and Related Disabilities, or LEND program, which is a federally funded interdisciplinary training program for professionals and advocates going into the field of developmental disabilities. In addition, she is the director of the Behavioral Intervention Program, which is a parent training program administered through our outpatient clinic. Through her work in the LEND program, Dr. Silverman has become passionate about policy and advocacy, and she is thrilled to be here today to talk to you about voting rights and voter accessibility for the disabled community, which is an extremely timely topic. So Dr. Silverman, thank you for being here today and sharing your perspectives.
Thanks so much for having me, and hi everyone. I know that I'm standing between all of you and the weekend, so I'll make this count. I'm just going to share my screen and we can get started. Okay. Okay. So hang on. Okay. So I'm going to start by telling you a little bit about the LEND program, and then we'll switch to voter accessibility, which is really going to be the main focus of what I'm talking about. But just to start, some of you may already be familiar with the LEND program, and if so, just bear with me. So the LEND program, as Susanna said, stands for the Leadership Education in Neurodevelopmental and Related Disabilities program. It's a mouthful, and it's a training program that aims to train professionals and self and family advocates to become leaders in the field of developmental disabilities. Our LEND program at Rochester is housed at the University of Rochester Medical Center, but it includes faculty and trainees from Nazareth College, SUNY Brockport, and members of the greater Rochester area and Western New York community. We're funded by a federal grant from HRSA, which is the Health Resources and Services Administration, and it's part of the Department of Health and Human Services. And we're one of 3 developmental disabilities focused centers at the U of R. The others are the Intellectual and Developmental Disabilities Research Center, which is the IDDRC, and it focuses on research related to developmental disabilities. There's also the University Center for Excellence in Developmental Disabilities, which focuses on creating community partnerships that foster and improve accessibility and inclusion for the developmental disabilities community in areas like recreation, housing, and employment. Oh, let's see if I can, hang on, sorry. Having trouble forwarding. There we go. Oops. Okay, sorry about that. So our LEND program really focuses on workforce development. So as many of you know, there are significant shortages of professionals and leaders who specialize in autism and developmental disabilities, and this results in really long waits for services. So we train professionals and advocates in the following disciplines that you see on my slides. And I want to highlight advocacy as a strong area of our training. So our program has self and family advocates who are faculty members and also fellows in the program, and they play a really large role in our training and all of our activities. The Rochester LEND is part of a national network of LEND programs. So there are 60 in the country and 5 in New York State, and they represent most states and US territories. Our LEND is the only program that's located in Western New York. All of the others are pretty close to New York City. And so we really serve this area in a way that the other LENDs in New York really don't. And I should say, for those of you in the audience who are advocates, professionals, or students in the field, we're always looking for our next crop of LEND fellows for next year. So if you're interested in the program, you can always look up UR-LEND online and contact either me or apply through our website. We're always looking for new people. So the reason that I brought up LEND is a big focus of our LEND training this fall has been on policy and advocacy. And we've been educated by a number of specialists and disability advocates on voting rights and voter accessibility. So people have shared their experiences facing barriers to voting and have discussed strategies that they've used for breaking down some of those barriers. So I am by no means a specialist in voting, but I really wanted to share what we've learned from the experts who've come to us and who've educated us. And please know that the resources that we share are really helpful to anyone who wants to vote. So even though the focus is on the disability community, I think most of the resources are broadly helpful. So just to start, in 2020, there were 35 million eligible voters with disabilities in the US. And an estimated 3.85 million had trouble voting. And that just includes the people who actively tried to vote. There are often a lot of people with disabilities who anticipate barriers and don't even end up registering. So this is probably an underestimation of the number of people who had trouble voting in the disability community. So studies show that disabled people vote at relatively lower rates than non-disabled peers. They register at lower levels, and they also expect difficulties at the polls at higher rates than non-disabled voters. So why is this important? I mean, I think probably anyone here knows why this is important, but first of all, it's important because everyone who wants to vote should be able to vote. And second, the disability community represents a large sector of the population. So if all of the people with disabilities who wanted to vote did without significant barriers, it could actually swing elections and ensure that candidates with knowledge of the disability community and those who support key disability legislation would have a better chance of being elected to office. So it gives a voice to disability policy. And that's why it's important to get everyone to the polls and to get everyone voting. So the first question is, what are the laws? There's a variety of legislation designed to ensure access to the polls for people with disabilities. Most people know about the ADA, or the Americans with Disabilities Act, but just in summary, it's a federal rights law that protects people with disabilities against discrimination. And Title II of the ADA requires state and local governments to ensure that people with disabilities have a full and equal opportunity to vote. This provision applies to all aspects of voting, including things like registration, site selection, and casting the ballot. The Help America Vote Act of 2002 requires all polling places to have at least one accessible voting machine. And I'll talk more about the accessible voting machines later. But this machine must provide the same opportunity for access for people with disabilities as for non-disabled peers. This means privacy must be maintained as well as independence in voting. The Voting Accessibility for the Elderly and Handicapped Act requires polling places to make registration and voting aids available to all individuals with disabilities. It also allows the right to move up in line if there are long waits and someone is having trouble standing. Finally, the Voting Rights Act has a provision for people with disabilities, and it requires officials to allow a voter who is blind or has another disability to receive assistance from a person of that voter's choice who can serve as an assistant. It also prohibits basing the right to vote on a person's ability to read or write, attain a certain level of education, or pass an interpretation test. So, when we were talking to self-advocates who really educated us on their experiences, we did hear stories about people at polling places, voters with disabilities being asked to prove that they could read, or about their level of education or competency. And this is illegal. And really anyone should be allowed to vote regardless of their ability to read or write and their level of education. So let's talk about some of the barriers to voting in the disability community. So one really has to do with language. And I would say that this is a barrier not only for the disability community, but for really everyone. I think that the language and the materials that we encounter when you think about registering, or if you look on candidates' websites to figure out what their platforms are, or even when you get to your polling place and look at the ballot, the language can be really confusing. So one thing that you can advocate for is really plain language, and a shift to having voting materials in plain language. So plain language means writing to your audience. So it doesn't mean like very overly simple language. It just means using language that people can easily understand. And the goal is to write using clear, straightforward terms, using only words that are necessary. So not a lot of flowery language in the periphery. And you really want people to be able to understand the message without spending a lot of time interpreting it. It should be pretty straightforward. Other aspects of writing that can be helpful is just using clear headings, using bullet points, being concise and to the point. Summary statements can be really helpful, and just using a clear layout. Sometimes pictures and visual supports also help. Other things that help with language access can be text-to-speech options and giving people access to sample ballots. And I would say I was looking through a lot of materials that are out there about voting, and the ARC has a really nice disability voter guide in plain English, just as an example. So another barrier to voting has to do with the physical space at polling places. So many polling places are buildings like churches and firehouses. And this often makes physical accessibility really hard. Polling places may have polling places must have accessible parking spots, and there has to be ample space for people with wheelchairs so that they'll be able to enter and exit their vehicles. If they don't have accessible parking spaces, they need to be able to create them with appropriate signage and also blocking off enough spaces so that there's room for a vehicle. They must also have an accessible path of travel from outside the building into the polling place. And this may include things like adding ramps, making sure that the doors are wide enough to allow for entry, making sure that the floors are flat and that there aren't barriers. Proper signage is also really important. You have to have an accessible route, but if there isn't signage showing where that route is and how people can use it to get to the voting area, then it's really not useful. So signage is also important and required. And if the path of travel to a voting area is not possible, then placing an accessible voting machine at an accessible location within the building that's separate is okay, but not preferred. So some people use absentee ballots or mail-in voting to avoid these physical barriers. However, this can't be the only alternative that's offered to the disability community for voting. There have to be ways for people with disabilities to vote in person at polling places. And the Department of Justice created an ADA checklist that's available online for polling places. It describes all of the requirements and parameters for accessibility. It's really long. It's about 25 25 or 30 pages, and it shows exactly how you measure everything and what's required. They also have some handouts that outline the 5 solutions for the 5 most common ADA access problems at polling places. And so these are just some resources that are available if you're interested. So using an assistant, many disabled people are able to vote and choose to vote independently. However, others benefit from using an assistant who can accompany them to the polls. Disabled individuals have the right to use an assistant of their choice. And this assistant can actually be pretty much almost anyone. It could be a friend, a family member, a neighbor, a care provider. They could also ask a poll worker to provide assistance. The 2 types of people that can't be assistants are an employer or a union representative. If an assistant is being used, it's really important for the assistant to understand their role, because as much as they may be trying to help, they can also be a barrier to voting if they don't really understand what their role is and what the parameters are around that. So first, an assistant should not assume that the voter needs help voting, even if they do have an assistant. The assistant should be present and available, but really follow the voter's lead and only provide supports when they're requested. This assistant should respect the voter's choice to vote independently if that's what the voter chooses to do. The assistant must also be really committed to ensuring that they don't influence the voter. So again, this is something that we heard from a number of the advocates that we talked to who shared their voting experiences, that they chose an assistant, and sometimes it was a family member or a trusted friend. And then when they got to the polls, their assistant really tried to influence their vote. And I think, you know, this was perceived as not coming from a bad place, but also not really, you know, it became clear that the assistant didn't understand their role and that the vote is really a decision that the voter makes, and there shouldn't be any discussion from the assistant around that. So assistants should avoid discussion or sharing personal political views or opinions during the voting process. And they should refrain from comments about the voters' choices. It's not a part of their role to do that. It's important to ensure that the voters' decisions are also kept confidential. So if someone serves as an assistant, then they really should not discuss what the voters' decisions were. And during the voter process, if the assistant is requested and present, they can do things like explain instructions regarding how to fill out the ballot, reword language to ensure that it's accessible to the voter. They can clarify meaning. They should not alter any of the content of the information provided. So it's really about clarifying and paraphrasing, but not altering the content. And again, it's paramount that they don't try to influence the voter's decision. The assistant can also do things like mark the voter's ballot based on the voter's choices. And they should provide the voter with an opportunity to review choices privately and to change choices privately prior to casting the vote. If an assistant notices errors like endorsing too many candidates in a particular race, they can review the directions with the voter. And so these are just all important points about the role of an assistant. And, you know, many assistants just don't understand the parameters of their role. So it's important to educate them and to make sure that they know what they can and can't do, and that it's really most important to follow the voter's lead. Okay. Sorry, my slides aren't forwarding. Okay, there we go. So next is casting the vote. So every polling place is required to have an accessible electronic voting machine or ballot marking device. And these machines really allow a voter to cast a ballot privately and independently using a variety of different functions. So I took these pictures actually from the Monroe Board of Election training materials for poll workers. So it shows, if you can see them, some features of the voting machine. So the basically, examples of how these machines provide accommodation. So a blind person can use a voting machine like this to listen to choices and then voice commands. Someone who has some issues with dexterity can use paddles that are kind of yes/no choices to navigate the machine, or they can use a sip and puff, which is basically like a straw where you sip air out or puff it in to navigate the ballot process. And people who have different levels of sensory processing are able to use multiple senses like sight and hearing to comprehend the ballot and to select their choices. So it's important to know that these machines are at polling places and should be available to everyone. And actually, that's a good point. I think it's important to know that although the machines are there to make voting more accessible for the disability community, anyone with or without a disability can request access to this type of voting machine, and it should be granted. So there is no need to prove that you have a disability. If someone asks you what your disability is, or if you have a disability, you do not need to answer that question, and you should be given access to the machine. Other barriers are poll worker knowledge. So right now it's really difficult for the Board of Elections to recruit and train enough poll workers to cover the elections. So all poll workers have to go through a training program. There's a lot of an educational component around accessibility for people with disabilities, and how to use the ballot marking device is a part of the training. However, just to become a poll worker, there's a lot to learn and remember. And so some of this information gets lost between when training happens and election day. So ultimately, regardless of that, it is the poll worker's responsibility to respect the rights and identities of voters with disabilities. That includes ensuring access to the polling place, to allow people with disabilities to vote without questioning their right. It's really only a judge who can restrict someone's right to vote. They need to respect privacy for the voting process, to allow people to have an assistant or to serve as an assistant if someone requests it, and to treat all voters with respect. So the question is, given all of those barriers, what can we do to make voting more accessible? So one thing that you can do is really to make a voting plan and to start early. So election day is really soon, it's on Tuesday, and there's still time to do research for this election. It's not a lot of time, but there's still time. And I think it's important to realize that, we have the upcoming election, but it's not really a one and done. So once this election is over, that means that you can start thinking about voting in the next election and give yourself time to really come up with a voting plan and to figure out what you're going to do. It's important to do things like check your registration and register to vote, especially if you've moved. Learn about things like early voting options to decide where and when you would like to vote. If you want to vote early, does it make sense to request a mail-in ballot? You may want to figure out where the early voting sites are. You also need to research candidates and then share your plan with others if you need assistance, so that you can ensure that you get to polling places or that you get your mail-in ballots in. And their Vote 411 has a first-time voter checklist that could be a helpful resource for people. Other steps that we can take to break down barriers are doing things like, we've talked about this a little bit, but we can recruit and train self and family advocates and also professionals in the field of developmental disabilities to be poll workers. We talked about poll workers, but really the group at a conference like this really knows more about developmental disabilities than anyone else. So we're probably the best people to be present at elections and in polling places to allow for accessibility. So considering becoming a polling worker is something that we could do. And the board, our LEND program met with the Board of Elections, and we had some of our fellows who are self-advocates discussed some of the barriers that they encountered at polling sites. And the Board of Elections was really open to hearing that. And they also shared that they are interested in having people from our community participate as poll workers. I think the Board of Elections really wants people to vote, and information will only improve the experience. So if you experience accessibility issues at the polls, it's important to share that feedback so that it can change in the future. And one last thing that you can do is contact state and local legislators and let them know what you're experiencing. So you can be in touch with them about your voting experience. You can also be in touch with them about bills that you believe in that may affect voter accessibility or improve the lives of people with disabilities in the community. Our LEND program this morning met with 3 state assembly members, and we talked with them about these issues. So I want to quickly go through a couple of resources that may be helpful. So the League of Women Voters has a website called Vote 411. It's really a great resource for anyone who wants to vote. It includes nonpartisan information about things like your polling site, registration, things like early voting and absentee ballots. There's voter information, and then there are sample ballots. And I have one feature that I really like is the Vote 411 voter guide, and I have a screenshot right here. You can enter your address and the website into the website. And then if you click the button, it lists the races that are in your district. So you can select different candidates within each race. And then it shows them kind of head to head, where it compares their answers to the same questions right next to each other so that you can make direct comparisons when you're thinking about their beliefs and priorities, just to ensure that you can make an informed decision when you vote. Some other resources. So the self-advocates Becoming Empowered have put forth a number of videos. So they have a Go Voter project, which provides some training for self-advocacy groups to help people with disabilities prepare to vote. They also have surveys that you can fill out after voting, just to share your experience. But some of their training videos have advocates who share their experiences voting and talk about how they respond when barriers were in place in polling places. So it just gives some examples of how you could respond if you encounter difficulties at the polls. It's helpful also to know about your protection and advocacy organization. So PNAs are a nationwide network of legally based disability rights agencies. They're federally mandated to protect and really advocate for people with disabilities. In New York, our PNA is Disability Rights New York, and they provide free legal services, resources, and information, and they can help you understand what your voting rights are. If you get stuck with the process, they can also provide accessible information, and they help with voter registration. And if you encounter what you think is a violation of your rights, you can also talk to them. The New York State Attorney General's office also has a civil rights number that you can call if you have difficulties. You can also contact the New York State Board of Elections. This is a really important page to look at. So a question that comes up a lot is what happens if you encounter access issues on election day at the polls? So what do you do if you show up and you're not allowed to vote, or they don't know how to use the voting machine, or, any number of scenarios, they won't give you an assistant. So there are numbers that you can call, and I have them up on the screen. The Election Protection Coalition is an organization that you can call for assistance on election day. They're a nonpartisan group, and they work year round just to ensure that people have an equal opportunity to vote. So that's the 866 Our Vote number. There are also resources for voters who are non-native English speakers that I have on the slide, and they allow for questions in Spanish, Chinese, Vietnamese, Korean, Bengali, Urdu, Hindu, Tagalog, and Arabic. And I'm sure there are others. And if you believe that voter access, that your access to voting has been blocked, or that there's been discrimination, the Department of Justice has a civil rights division and a voting section that can also be contacted. So I just want to end, I have 2 quick slides here. For the autism community, if you are planning to vote but still have questions about how to proceed, the Autistic Self-Advocacy Network has Your Vote Counts voting guides, and they're really nice. They have both easy read and plain English editions, and they provide a lot of clear information on how to vote and what your rights are. And finally, the American Association of People with Disabilities has the Rev Up voting campaign, and it's a really nice resource. It reviews a lot of the topics that I covered in my talk today. So I thank you all for being here with me, especially on a beautiful Friday afternoon at the end of the day. I guess I would end with just saying, remember to vote, and your vote does make a difference. So I hope you all make it, and I hope that you don't experience barriers. Thanks for having me.
Dr. Silverman, thank you for this discussion today. Again, this was such an extremely relevant topic, and I really appreciate the focus on the practical as well as ideas about what we personally can do to support accessible voting. I think discussion of practical access to a basic human right is highly illustrative of equity and equity issues, so thank you. You have heard from a variety of experts today on very different facets of health equity, and this only serves to highlight the complexity of ensuring access and equity for people with disabilities. Thank you so much to our panelists who have provided excellent overviews of both high-level and on-the-ground perspectives, as well as ideas for strategies to promote equity in our own personal and professional experiences. We have a few minutes left for questions, so I will read a couple. We had an anonymous attendee ask about work being considered to look at correlation between financial stresses and household income and instances of trauma experienced. And I know Dr. Paciorkowski addressed this a bit in the Q&A, but I'm wondering, Dr. Paciorkowski or Meg, if you have thoughts about what an analysis of this question might look like, or if you have ideas about how to get involved in this type of exploration.
Meg, do you want to go first, or I have a couple of thoughts, but we could do it in either.
I think this is your area.
Well, I will say that during your presentation, I was struck by the obvious connectivity between what our group was looking at. Our data was drawn from public sources. None of these surveys, the U.S. Census or the other surveys, have, to my knowledge, any questions addressing experiences with trauma. And as we're rounding out what our own data collection in the future might look like, I do think that this is an important area to look at.
Thank you so much. Meg, do you have anything to add?
Other than I'm just excited to hear of the interest. Yeah, thank you.
That's a great question. Thank you. Here's a question for Dr. Kuo. Do insurers pay attention to the HRSA roadmap? And relatedly, do you have any comments on its relationship to the Medicaid waiver?
Okay, am I on? Yes, okay. Do insurers pay attention in a Medicaid waiver? I know Medicaid, CMS and Medicaid has looked at, yeah, models and braided models of funding. And in New York State, for example, with the New York State first 1,000 days, the payers were at that table to discuss those types of opportunities. And like a couple of examples would be for being able to pay for and screen for programs such as the Healthy Steps model, which is not specific to disabilities, but is part of the addressing the at-risk factor, as well as addressing the life course to be able to promote development, which then is, and a lot of the folks that are employed, within those models, which the payment models that would align with, say, the Medicaid waivers that New York State's looking at, does, encompass interdisciplinary teams, which addresses the structural determinants of health. And that is really the best relationship between the two that I do know of. Are the commercials payers looking at them specifically? Not that I'm aware of, other than I know some of the foundations that are associated with with some of the commercial payers in New York State have been looking at supporting some of those same programs. So I think that you will see that under the value-based payments, that they are looking at trying to move away from, we'll pay for your service if you come in and see the doctor, to let's try to pay for and fund a variety of programs, which is really more about promoting health and wellness. How that's going to turn out is what Massachusetts has had some more success at trying to line that underneath their waiver. New York State's looking at that. And I suspect you'll see more to come. So that's more of a longer term development.
Thank you so much. I think we have time for one more question. Dr. Paciorkowski, this came up for you. A comment saying nice delineation of nodal opportunities for intervention. Do you have thoughts about what interventions might be relevant to address some of the equity issues that you've highlighted in your work?
Well, our group, I think, has come to the preliminary observation that people who are poor don't have enough money. And, that sounds kind of obvious, but one of the ways that policy in industrialized societies has striven to kind of raise all boats has been to provide appropriate subsidies to help families cope with different economic times. And that in this country, we don't have consistent policy to help families who are confronted with raising a child with special needs, and are left to sort of navigate the economic consequences of that on their own. So that is one area that a general observation. I think more specifically looking at particular points, whether it's helping families complete schooling. We do think that there is an interruption in parental schooling that can be addressed through policy. Those are just preliminary thoughts, but we're striving to get a better handle on that.
Thank you so much. And I think you and Dr. Kuo and Dr. Silverman all gave ideas about what we as individual citizens can do to personally advocate for health equity for people with disabilities. And it's something that perhaps after today, everyone will be a little bit more aware of. Look out for those opportunities and see what you can do to contribute to promoting equity for all of those in our community. I will take the last 2 minutes to thank our panelists again and to thank all of the attendees for spending your Friday afternoon with us. As a reminder, if you are a psychologist, please finish the SurveyMonkey survey that includes your psychology license number if you're looking to seek CEUs for your time today. For those who are not seeking psychology CEUs, you will receive a link at the end of the conference for the overall conference evaluation. And it is through that evaluation that you will be able to request a continuing education certificate that you can use however you need. So with that, we will close our afternoon session and hope to see you tomorrow morning at 9 o'clock for the last session of our weekend conference. Have a lovely Friday. Thank you.